I'll be giving a talk today on lumbar degenerative disc disease. I'll try to keep it in the 20-minute time frame. As Dr. Spoonmore said, I was a resident at USC and I did a year of spine fellowship in New York at Hospital for Special Surgery, and I just joined the Spine Center in September. Very briefly, as Dr. Spoonmore alluded to, we are expanding the Spine Center's outreach. We're going to open up a clinic and do some surgeries up in Santa Clarita at Henry Mayo, and that's supposed to start actually in November of this year. So in addition to all of the slides that Dr. Spoonmore went over, that's just one additional point that we're very excited to start next month. But I'll go ahead and get started here on lumbar degenerative disc disease. This is an outline of what I hope to cover in the 20 minutes. We'll start with a brief background, talk about the relevant anatomy, go over the clinical presentation of lumbar degenerative disc disease, and finally, treatment options. So in terms of background, what is lumbar degenerative disc disease? It's really important for us to define it because it's a commonly misused term, both in the vernacular and even the scientific literature. There's in fact an entire paper trying to investigate what is lumbar degenerative disc disease in terms of the definition, and it's really poorly defined. And there's significant variability in both colloquial speak and the scientific literature, and there really is no consistent definition. It probably exists somewhere within this schematic between back pain, discogenic pain, disc degeneration, and central sensitization. But as I said, really it's a very vague term that's probably misused quite frequently. So for purposes of this talk, I define degenerative disc disease as an age-accelerated structural failure of the intervertebral disc causing pain. The disease is different from regular intervertebral disc degeneration as seen on the radiographs because disc degeneration, as I'll go into on the following slides, is a natural phenomenon and is not necessarily indicative of a pathologic process or something we even have to intervene on. So two patients with the same exact radiographs can have completely different manifestations of those radiographs. One patient may have debilitating back pain, and another patient with the exact same radiograph showing degenerative disc disease may have no symptoms at all. And I would argue that patient doesn't even have degenerative disc disease. So why is this important? The intervertebral disc is sort of the holy grail of spine. We've yet to figure out how exactly to preserve its function or even regenerate the intervertebral disc. And it's important to figure this out because it's thought that the progression of disc degeneration is actually like the catalyzing event that results in a degenerative cascade throughout the lumbar spine, where you get disc height loss and then you get increased stress in the posterior elements, including the facet joints. And then these facet joints basically develop arthritis. They become much larger, and then the underlying ligaments start to thicken as a response to the arthritis. And that's how you actually end up getting spinal stenosis. So if we could figure out how to prevent disc degeneration or even regenerate the disc, we would do quite a bit to alter the natural history of degenerative changes in the lumbar spine. So in terms of epidemiology, low back pain, as we all know, is incredibly common. Studies have shown that 70 to 85% of adults will be affected by low back pain at least at some point in their life. It's the most common cause of disability in adults younger than 45, and it's responsible for indirect costs exceeding about 100 billion per year, according to some studies. Yet despite its enormous prevalence, like I alluded to previously, we really don't have a great treatment. And this is due to many factors, including the heterogeneous nature of the disease process, multiple confounding pathologies I'll get into in these later slides, and it's really variable clinical presentation. A couple slides just very briefly on anatomy, because it's important to understand the anatomy in order to, one, identify the patients with degenerative disc disease, but also to understand possible treatment modalities. So this is a busy slide, but very briefly, the disc is composed of the central nucleus pulposus, which is really mostly type 2 collagen, and this has a very high affinity for water. And then the nucleus pulposus is surrounded by an annulus, which is mostly type 1 collagen, and this is really the strength layer of the disc. And it's got a bunch of concentric rings that alternate in different directions to create a tensile strength that really resists protrusion of the nucleus. And when this annulus starts to weaken, it may be the sort of inciting event that results in intervertebral disc degeneration. And it's also obviously associated with lumbar disc herniations. This is a very, also busy schematic, but the key point here is to show that there's really two separate sources of nutrition, as well as diffusion into the disc. And the disc overall is a very oxygen poor environment. So that's probably the biggest challenge in developing regenerative strategies to regenerate the lumbar disc, is it's a very oxygen poor environment. So it really favors catabolic events as opposed to anabolic events. In normal aging, Changes in the disc occur earlier than in other tissues throughout the body. And once again, this is a natural phenomenon. This is not necessarily a pathologic process. Over time, the end plates demonstrate decreased permeability, resulting in diffusion of fewer nutrients, favoring degenerative or catabolic processes. And although this is degenerative, like I said, we do consider this to be part of normal aging. And this is distinct and different from what we call degenerative disc disease, which is an abnormal increased rate of degeneration resulting in actual structural failure of the disc and resultant back pain, versus intervertebral disc regression or degeneration is just a natural phenomenon. In terms of the etiology, it's complex, and it's like many things in medicine, it's an interplay between natural changes as well as genetic and environmental factors. Obviously, the decreased nutrient supply as we age due to end plate changes plays a role, but there's certainly a genetic component. Twin studies have shown that up to 70% of degenerative disc disease can be linked to genetics. There are various genetic polymorphisms that I won't get into in this talk, but these have been identified to resulting in structural changes in the disc and accelerated degeneration via catabolic and pro-inflammatory pathways. And lastly, as I stated before, there are environmental factors at play as well, such as obesity, smoking, atherosclerosis, and these have all been shown to be associated with progression or development of degenerative disc disease. Briefly, we'll talk about the clinical presentation and diagnosis, and really the bulk of this talk will be on the fourth bullet point, treatment. So the signs and symptoms in a patient with discogenic back pain can vary quite significantly. And this is, once again, really one of the challenges of dealing with this problem. Patients will typically report transverse lower back pain that radiates towards the hips or sacroiliac joint. They tend to describe sort of a mechanical pain that's worse with flexion because flexion tends to load the disc and place increased stress across the disc. And this is in contrast to patients with significant facet arthropathy or spinal stenosis, because these patients tend to have worse symptoms in extension. But of course, many of these pathologies can occur together, and a mixed picture is frequently seen. Radicular symptoms such as leg pain or numbness or weakness tend to be absent in patients with pure degenerative disc disease, unless they have an additional herniation or some sort of stenosis of the foramen or loss of significant disc height. But as with all pathologies in medicine, not just spine, thorough history and physical exam are crucial in identifying the diagnosis, and assessing for other causes of low back pain is key before we hone in on the diagnosis of degenerative disc disease, because there can be other pain generators such as renal stones, aortic aneurysms, pancreatitis, or tumors that can manifest as low back pain. Obviously, this is a long list of the differential of low back pain, and other causes should be ruled out, but most of these causes, other items on the differential diagnosis can be ruled out purely with a good history and physical exam. But the key point here is to just remember there are other pathologies that may not be spine related that may manifest clinically with just low back pain. In terms of imaging, the X-ray is really the workhorse of diagnosing degenerative disc disease. Upright standing plain films are best. Really, you only need 2 views, an AP and a lateral. It's always important to remember that plain films can show degenerative changes in an asymptomatic patient, so radiographic findings alone do not identify degenerative disc disease. On the AP and lateral images, you should look for disc space narrowing, as seen on the picture here on the right, as well as end plate sclerosis and any sort of a vacuum disc phenomenon. If you do get flexion extension views, look for motion to rule out any sort of instability. After plain films, advanced imaging can be considered, but is usually not necessary in the absence of neurologic symptoms such as leg pain, weakness, or sensory changes. But if you do get an MRI, some findings on MRI that are indicative of degenerative disc disease include loss of disc height, shown on the image on the top right there, as well as the presence of annular tears or signal changes. Particularly on the T2 images, you can have a black disc as shown on the top right between L4 and L5. You can see that that disc is much darker in signal intensity compared to the levels above and below. And those are the key things to look for in terms of MRI findings. But once again, really an MRI is not needed in a patient with just degenerative disc disease and the absence of neurologic sequelae. And not to belabor the point, I know I've mentioned this 2 or 3 times already, but if you get an MRI in someone who's above the age of, say, 50, over half these patients are going to have some sort of pathology in the disc that you can find. And this is just a study from 2009 that looked at 200 healthy patients to report the prevalence of degenerative disc disease. And these were asymptomatic patients. And these were patients between ages of 30 to 55. And basically at L5S1, 53% of these patients had degenerative disc disease. And once again, these patients were asymptomatic. So the majority of patients above the age of 50 are going to have changes on MRI that are consistent with degenerative disc disease, which is why I said you really don't need an MRI in these patients, because you'll probably find something that's not going to change your management. So moving on to treatment, which can get very controversial. I'll talk about both non-operative, operative, as well as some biologic therapies that are coming down the pipeline. So the treatment options for degenerative disc disease are predominantly limited to non-operative treatment, such as physical therapy or pain management. And patients who fail non-operative management with degenerative disc disease may benefit from operative intervention in the form of lumbar fusion or lumbar disc arthroplasty. And I'll go into all of these treatment modalities on the next few slides. So in terms of non-operative treatment, this is really the mainstay for treating patients with symptomatic degenerative disc disease. Approximately 90% of patients on average with lower back pain and degenerative disc disease will have resolution of their symptoms within 3 months, honestly, with or without treatment. Most will have cessation of discomfort within about 6 weeks. So conservative measures, including the modalities listed on this slide, should always be exhausted prior to considering any type of surgical management. The most commonly used conservative modalities include physical therapy, pharmacologic interventions such as anti-inflammatories, lifestyle modification, particularly smoking cessation in smokers. Weight loss is always beneficial as there's less stress across the low lumbar spine. And there is some evidence for psychologic or cognitive behavioral therapy, which I'll get into a bit, as well as other modalities, including acupuncture and chiropractors. So in terms of physical therapy, the main function of physical therapy is to strengthen the core muscles to take stress off of the degenerative discs to hopefully relieve pain. And there have been multiple studies demonstrating the benefit of physical therapy in patients with chronic low back pain. Most physical therapy programs focus on strengthening the core muscles, the abdominal walls, the lumbar musculature. And there are some more advanced physical therapy regimens looking at sort of motor control exercises, looking at gait, looking at mechanics of how patients sit and stand that can be beneficial as well. As I mentioned before, there is some evidence for acupuncture as well as yoga. And really, I think any of these modalities are reasonable to treat patients initially with lower back pain. In terms of pharmacologics, NSAIDs are obviously the go-to treatment for patients with significant pain to help decrease the inflammation. There are multiple studies have looked at the efficacy of different anti-inflammatories, and no specific anti-inflammatory has been found to be better than another. But they do generally work for short-term symptomatic pain relief for patients with acute back pain. Muscle relaxants may be effective, but obviously you need to caution against the side effect profile. And some recent studies and some older studies have started to look at antidepressants because there's a well-known overlap between low back pain and mood disorders. And so in patients who do have identifiable mood disorders, starting tricyclic antidepressants or tetracyclic antidepressants have been found to be effective in the scientific literature. However, SSRIs were not particularly effective when looking at the outcome of lower back pain and decreasing compromised function. As I mentioned before, cognitive behavioral therapy has received some attention. It's long been known that, as I said, there's an association between chronic low back pain and a disordered thought process, and cognitive behavioral therapy has emerged as an effective non-operative treatment, yet many patients feel a stigma and don't seek psychiatric care for their diagnosis. One study out of Canada reviewed 9 different randomized controlled trials looking at cognitive behavioral therapy and other web-based interventions, and they found that this sort of therapy reduced short-term disability from lower back pain and degenerative disc disease, as well as caused a decrease in pain reduction. And interestingly enough, the North American Spine Society, which is one of our major academic societies in spine, actually gave a grade A recommendation, and it was cognitive behavioral therapy was one of the very few treatments given a grade A recommendation in combination with physical therapy to help improve pain levels in patients with lower back pain, possibly secondary to lumbar degenerative disc disease. While significant advances have been made over the past few decades in the execution of the previously mentioned non-operative strategies, there's been a growing interest in better understanding the pathophysiology of degenerative disc disease at the cellular level, and this has led to some cell-based treatment strategies that hope to be not only disease modifying, but also symptom modifying. And I'll go over very briefly some of these studies that are still very early in their development. So platelet-rich plasma has received quite a bit of attention in treating lumbar degenerative disc disease, as have mesenchymal stem cells that have been harvested from either bone marrow or fat. And a few studies have started to look at taking chondrocytes and implanting them into the degenerative lumbar disc. And one study out of Japan has actually looked at taking good, healthy nucleus pulposus cells, which once again, as I mentioned at the beginning of the talk, are that inner layer of the disc, and transplanting them from a good disc to a degenerated disc to see if there's an improvement in clinical symptoms. So I'm sure many of us know what PRP is, but it's just autologous plasma that's spun down with a high platelet concentration. And some basic science studies have shown that PRP can downregulate some of the inflammatory molecules such as IL-6 and IL-8 and help attenuate hyperalgesia in the lumbar disc. And this is sort of the scientific or basic science background for why this may work clinically. So what's the evidence? I won't go into all three of these studies in significant detail, but basically there are three reasonable prospective, two of which are randomized controlled trials that do exist, demonstrating some improvement in lower back pain after a PRP injection directly into the disc in patients with degenerative disc disease. Mesenchymal stem cells continue to be a hot topic, and they're becoming even more thoroughly investigated in spine. But in vitro studies or basic science studies have shown that stem cells can express growth factors such as TGF-beta and VEGF, which are known to stimulate local tissue repair. And that's sort of the background for why these are being investigated in degenerative disc disease. And so there are, as similar to PRP, there are two well-done prospective studies looking at the efficacy of mesenchymal stem cell implantation into patients with degenerative disc disease. And the study on the left showed improvement not only in MRI findings, but also overall function in patients with lower back pain secondary to degenerative disc disease. And the middle study also showed similar results. 85% of patients actually had a reduction in a disc bulge size after they had stem cells injected. And that study was actually 6 years follow-up. And there's an ongoing phase 1 clinical trial. Currently only 10 patients have been enrolled, but we're eager to see the results. And so biologics to treat degenerative disc disease, many people are hopeful that this may be a better solution than some of the current treatment options that we have. Currently, there are 20 ongoing registered clinical trials looking at biologics to treat degenerative disc disease. 16 are currently investigating various types of stem cells, and 4 are investigating disc-derived cells such as nucleus pulposus cell transplant. But this is an area that's getting a lot of research funding and NIH funding. Because as I alluded to in the first couple slides, lower back pain is a major area of healthcare expenditure. And so if we can figure out how to regenerate the disc in an oxygen-poor environment, that would be incredibly beneficial for patient outcomes. And so I'll finish up the 20-minute talk here on operative treatments for patients with lumbar degenerative disc disease who fail conservative management. So really the treatment options boil down to just two things: fusion versus disc arthroplasty. And I'll start with fusion. This is all very controversial in patients with just purely back pain and no neurologic sequelae, and I'll try to explain why it's controversial. But in the early 2000s, there were quite a few studies coming out of Sweden, and these studies basically found that surgical patients with lumbar degenerative disc disease and no neurologic sequelae, so no weakness, no numbness, no lower extremity leg pain, after they underwent lumbar fusion, they did demonstrate some sort of improvement in both pain scores and functional outcome scores. And actually, in patients who were depressed, they also had an improvement in their depressive symptoms. And these studies went on to look at the cost effectiveness of fusion versus non-operative management. And they actually found higher costs for fusion, but they reported that the incremental cost effectiveness ratio favored fusion when you were looking at loss of days lost to work and other societal costs. So that was one study, but these other studies from Norway showed less enthusiasm for operating or fusing patients with purely lower back pain. And these studies from Norway basically showed no long-term difference between surgery and non-operative management. And non-operative management also included cognitive behavior therapy and physical therapy. So these studies really showed no difference in fusing patients with purely lumbar degenerative disc disease and back pain. So several studies have tried to figure out why do some studies show benefit and why do other studies show no benefit of fusing patients with lumbar degenerative disc disease. And there's a lot of confounding variables. But some of the confounding variables that predict a poor outcome after surgery include workers' compensation patients, a history of prior surgeries, low income, older age, litigation, tobacco use, depression, etc. Patients who may have a positive outcome after fusion, these patients tend to have low neuroticism, a low disc height, and they tend to be younger patients. But once again, this is all very controversial and not very well understood, to be honest. So a more recent study looked at 5 randomized controlled trials, a total of 700 patients randomized to fusion or non-operative treatment for discogenic back pain secondary to lumbar degenerative disc disease. And overall, when the data was pooled, there was no really statistically significant difference between patients undergoing fusion versus non-operative treatment. And so overall, the results are pretty mixed. Most studies have shown some improvement in pain and disability in the short term, but obviously when you do surgery and fuse a level or 2 levels, complications can arise. One major issue with the current state of literature regarding fusion in this population is it's a very heterogeneous population that undergo fusion, and it makes it really difficult to draw any meaningful conclusions from this treatment. And these challenges are simply reflective of the difficulty of appropriately diagnosing this condition and our lack of, honestly, full understanding of the pathology. So a lot of work to be done here. And I'll finish up the talk just talking about lumbar disc arthroplasty. This is the other surgical option in the management of patients with lumbar degenerative disc disease. The original lumbar disc arthroplasty was designed in the 1980s and underwent several revisions over 2 decades before it was FDA approved in 2004. It was actually FDA approved before cervical disc arthroplasty. And since 2000, there's been great interest in arthroplasty in the spine community, and there have been hundreds of publications on PubMed looking at lumbar disc replacement in patients with lumbar pathology, and quite a few randomized controlled trials have showed improved outcomes compared to fusion with up to 2-year follow-up and even longer follow-up. However, and I'll get into this a bit, the indications for lumbar disc arthroplasty are very narrow. It can be technically challenging. There's insurance reimbursement concerns, and there's a lot of reasons that lumbar disc arthroplasty hasn't quite got the enthusiasm that cervical disc arthroplasty has received. But this is just an overview of the current state of the literature with regards to disc arthroplasty. There are 5 FDA IDE trials, all with 5-year follow-up, and another 5-year study out of Sweden that used a couple different implants. And there are a couple abstracts that exist in the literature that have up to 10-year data or 10-year follow-up after lumbar disc arthroplasty. There are a couple of meta-analyses looking at randomized controlled trials with up to 5 years of data. And these basically, when you pool these initial IDE trials, there were 5 of them. The pooled data shows basically it does favor disc replacement in terms of ODI or a functional outcome improvement and compared to fusion. And pain scores also tend to be less in the disc replacement group compared to the fusion group, but these don't typically reach statistical significance at 5 years. And so, when people first, or when surgeons first became interested in lumbar disc arthroplasty, the thought was that by preserving motion, you would get less degeneration of adjacent levels in comparison to a fusion. Because when you fuse a patient at one level, there are some studies that show up to 1/3 of these patients will require another surgery at an adjacent level within 10 years. So the thought was by continuing motion, you would have less of this adjacent segment disease. And some studies have shown that that actually is true, but that also is another point of controversy. And so the adjacent segment disease, whether or not it's less in lumbar disc arthroplasty versus fusion, is to be determined. I think most people would agree that it is, but the problem with lumbar disc arthroplasty is in the recent literature, there have been quite a few studies demonstrating complications, which decreases the enthusiasm for lumbar disc arthroplasty. And most of these papers describing increased revision rates after lumbar disc arthroplasty were published sort of between 2006 to 2010. And what's interesting is you see this top graph here, that there was initially, as I alluded to earlier, quite a bit of interest in lumbar disc arthroplasty. But as those studies came out that showed higher revision rates and possibly additional complications, the enthusiasm for lumbar disc arthroplasty has decreased almost 5-fold. But it's almost an opposite trend of cervical disc arthroplasty, which continues to get more and more interest in the spine community. So, lumbar disc arthroplasty in the setting of lumbar degenerative disc disease, what's the summary? Where do we stand with disc arthroplasty? The biggest challenge is really identifying the patient that can do well, because if you can identify that patient, I think disc replacement's a reasonable option, but they're very rare patients that actually I think are indicated for disc arthroplasty. Typically, these are younger patients, active patients with discogenic pain who failed non-operative management without any additional pathology. And if you compare these younger patients to patients who receive a fusion, it appears that they do at least as well, if not better, with potentially a lower reoperation rate and less adjacent segment disease, but you have to be aware of some of the complications that can be associated with disc replacement compared to fusion. So in conclusion, lumbar degenerative disc disease remains a challenging area in both diagnosis and treatment. Thorough workup is vital. A lot of it can be just a physical exam and a history, but there are many confounding pathologies which should be ruled out prior to diagnosis of pure lumbar degenerative disc disease. Management of these patients is almost always non-operative, and this should be fully exhausted prior to considering any surgery for these patients. As I mentioned, non-operative treatment modalities include physical therapy, anti-inflammatories, even antidepressants in patients with a psychologic component, as well as cognitive behavioral therapy can be reasonable. Yoga, acupuncture, chiropractor, I think are also all reasonable if the patient feels they're getting a benefit. Main operative interventions at this point include, as I mentioned, fusion or arthroplasty. Arthroplasty can be considered in a small subset of patients and may have some advantages, but like I said, I think there are very few patients that truly are indicated for lumbar disc arthroplasty. And the future is exciting in terms of regenerative medicine and biologics. Some of those initial studies that I very briefly went over do show some promise. They have a lot of basic science background for why they could work clinically. And a lot of us in the spine community are eagerly awaiting the results of some of the ongoing large randomized controlled trials looking at biologics in the treatment of lumbar degenerative disc disease and lumbar disc regeneration. But with that being said, I try to summarize all of this into a 20-minute talk. I know it was a lot, but happy to answer any questions.